Hello, everyone, and welcome to today's webinar, Trauma Verification's November Q&A Web Conference. Before we get started, I'd like to go over a couple of items so you know how to participate in today's event. You have joined the presentation using your computer speaker system by default for audio. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. We do suggest joining via telephone for best sound quality. I would now like to introduce Molly Lozada, Trauma Verification Program Manager. Molly?
Thank you, everyone, for joining today's webinar. It's only going to be me today, Molly Lozada, the Program Manager for the Trauma Verification Program. And I'm just going to go over a couple of things that are important for you to follow. So for continuing education, to qualify for CE, you must attend at least 50 minutes of the educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar, ending with instructions on how to claim those. If you have any questions regarding your CE or during the webinar, please email us at cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patients at your trauma center. So we're going to go ahead and get started. So I'm going to cover Rachel's segments as well, so I may be skimming through a couple of things. To get started, for new trauma centers or new participants, please have a copy of your resources manual. If you don't have a hard copy, you certainly can download a copy from the website as a PDF. There's a CD section in our webinar that we will be referring to. In addition to the manual, and I just discovered this at a recent conference, a lot of trauma centers are not aware that you have to use the clarification document and the verification change log in conjunction with the resources manual. So in my finding, there were questions that were coming up that we had already made changes to, and they were not aware of those. So please be sure that you're using not only the manual, but the clarification document and the verification change log. As I mentioned, these documents are available on the website. You can download them. I have not sent out a recent documentation due to Clinical Congress and TQIP, and I will be sending one within the next week with any possible changes. So please visit our resources website to download the most current copy. And these are just a few snapshots of what they look like. That's the clarification document, and this is the change log. They can be filtered by level, CD number, and whether or not there was a recent change. The webinars are recorded during the session and will be posted within 1 week of the ACS on the ACS YouTube channel. You may also access them via the VRC Resources webpage at the link noted. For those of you that are new to our process or our webinars, we do record these, and all prior recordings are available on the website going back to June of 2016. So please feel free to visit those webinars if there are questions that we may not cover during today's webinar. All questions are pulled directly from the question submissions. There have been no edits made to the content. If your question is not answered today, the question may require more information and will receive a response from ACS staff within 1 week after the webinar. Just a few announcements. The next webinar will be scheduled for Friday, December 15th, 2017. The deadline to submit your questions will be Friday, December 1st, 2017. And the time, please note the time. We're going to have the webinar at 1 p.m. Central Standard Time. So from 1 to 2 p.m. Central Standard Time. Again, I know you guys have been hearing us talk about the stakeholder public comment website. I've been to 3 back-to-back conferences, and this has been the topic of discussion. And I know many of you already are aware of this, but I also want to stress how during those discussions, you know, questions were brought up, and we have instructed folks to go back in there, even if there's a chapter that we've completed, like we've completed Chapter 6, as you see here on the grid. Even if we've completed a chapter, this online tool will be available, you know, during the whole entire revision process. And, you know, so we've already started on Chapter 9, Orthopedics, 10, Pediatric, and 19. 15, which is Trauma Registry, for a lot of the folks that were really concerned about the Registrar and the 500-750 number, and if we're going to change that and, you know, edit that and omit word that's in there. This is the opportunity that you have to make your comments and your recommendations for us to go ahead and make changes to that. And I will say that is going to be a change. For those of you, and I know it's not on here yet, it's Chapter 16, the PI section. A lot of you had concerns about whether or not we were going to add a PI coordinator as a requirement. And while I have a tick list of things that I continuously respond to in my webinars, as you all know, it comes up from time to time, I do have a running list of what you know, you are saying, but I also need you guys to go on the website and add your commentary to it. And it's not just a Molly change. It's something that's going to improve your trauma center and your processes. So, you know, so please go on our website, on the public comment website, and make whatever suggestions you have for any of the standards or anything you would like to see that's not currently there. As I said, for example, a PI coordinator, which is truly important for level 1s and 2s and possibly 3s. So take the time to do that. Just a couple of things, as I said before, I'm going to skim through a couple of these things. Some resources for new trauma program managers, and we're going to build off of the frequently asked questions and the tutorial we have for first steps. So they're available on the resources webpage. Just a few scheduling reminders. This is a new hub for new participants that are joining a program. This is where you would access and create an account. And basically what that does, it's going to create an account through TQIP, and which links into the verification program. And then you can request a site visit. For those of you that have an account already, you would have received login access. What I have discovered is that if there is a change in your TPM or trauma medical director or your C-suite, you can make those changes through this this web page. However, the challenge now is that I'm encountering is that if the trauma program manager has left, obviously they don't have a login. So if that's the case, if you're new and you don't have a login, you can go ahead and email us at either the COTVRC webpage or the TQIP at facs.org. Both of us will definitely get you set up with an account login. As you know, site visit applications, we're asking for real 13, 14-month lead time. Rachel is currently scheduling for December 2018 and into 2019. We are closed for 2017, and as you can imagine, there's a lot of site visits coming up for renewal. So if you have not yet submitted an application, please do so at your earliest convenience for a visit in 2019. For new trauma centers, again, we're available for December of 2018. And one of the common questions I get is this applies to consultation visits? And it does. When we talk about scheduling in closure months, we're talking about consultation, verification, and re-verification. The only allowance, if you will, that we provide trauma centers is for on-site focus reviews. Those trauma centers have a short period of time, and we will accommodate those site visits based on the date that they have to have those visits scheduled. Again, OTL, if you are level 1, just be sure that you submit the OTL form. I will cover for those trauma centers that have had an OTL form completed in the past and it's been vetted. I will cover that in a slide coming up here shortly. But if you're a new trauma center, never been through the process, you're a level 1 or a level 1 that's not yet had a verification visit under the Orange Book, you'll need to complete that documentation. Alternate pathway, again, if you are a trauma center that have non-board certified, foreign trained physicians working in your trauma center and have not yet gone through the alternate pathway, you want to make sure that you let us know with ample time, so that way we can go ahead and get their information vetted and allow them to follow the 8 criteria listed on the web page. And if you do have someone that's gone through the alternate pathway, be sure that on the site visit application you indicate who that person is, and also indicate whether or not they've undergone review by the alternate pathway. PRQ questionnaire, again, just touching on this, for some of you, I often get emails asking where's our logins, and I realize that the application is sent 13, 14 months ahead of time, and Anita sends out an acknowledgement saying thank you for your application, and that's kind of filed away. While in that email itself, if you scroll down towards the bottom, you will see your login information. And again, I realize that we're talking about you're looking at that pretty early on, but you do have access to your online PRQ fairly early in the process. And again, if you want to download a copy of the online PRQ, you can go ahead and do that, in Word. I realized that the Word documents were, some were updated, some weren't updated, but we have since updated all the documents on our webpage to follow the online PRQ. So go ahead and download a copy of that, so that way you can at least get started and dissect the PRQ as you wish, with ortho, neuro, and any of your specialty reviewers. Site visit application, again, just quick rundown. Do not send any payments with your application. I think pretty much everyone's familiar with this. We no longer are asking for payment up front. You will be invoiced with the TQIP on an annual basis based on your anniversary date. So just be on the lookout for that. If you are interested in seeing what the next fee structure is for your next site survey, because the fees will change based on the year, please visit the website down at the bottom under fees, and it'll give you a breakdown for a 3-year period. Scheduling site visits, as many of you know, Rachel schedules site visits somewhere within the 90-day range. She'll send you an email, and typically what happens is she'll send that out with just kind of confirm the dates with you based on her work with the lead reviewer, and once that is confirmed, then she'll send you the confirmed dates. I do want to say something that we have just started. There's a pilot process that is undergoing. Not a lot of trauma centers are in this. I think there's like a handful, maybe 5 or so, and you have already been contacted. Basically, the pilot is not necessarily you providing us a 2-month time frame, but rather you providing us a date, two days, say December 1st and 2nd, that you truly want us to come out to your trauma center and do the survey. And what that really means is that Rachel will work with the reviewers to then schedule them to come out on that December 1st and 2nd date. Again, this is just a trial. We're trying it out with a handful of trauma centers and see how this works. And if it's a success, then this is something that may be considered to be changed in the future. But so don't be surprised if you see an email from Rachel just saying, if you're willing to give us a 2-day time frame, and we're going to go ahead and do that. And the goal of that is that way when we're coming in, and you're not waiting for us 90 days prior, you have no idea, but this actually gives you time to set up your chart reviews and your cases and get your meeting rooms and get the folks you need for the site visit. And like I said, it gives you an idea of when we're coming in, or the date that we're coming in. Again, this is just about the site review preparations. We're still getting questions about this. The reviewers will actually go through the ACS to schedule their visit or make their travel plans, if you will. And oftentimes you will know, you will not get a copy of their itinerary. You kind of have to ask for it, and you can go through the reviewer to get a copy of that, or you can ask Rachel to obtain a copy for you. The reviewers will, again, schedule that through the ACS. The hospital will arrange and pay for the site reviewers' hotel accommodations for one night, as well as coordinate their ground transportation. If you are in a trauma center where the reviewer has to travel an extra day, you certainly are not required to pay for that, but please contact Rachel and let her know that a reviewer is asking for additional accommodations, and we will take care of that for you. Again, the reviewer's contact information and survey dates, etc., will be provided to you within 90 days of the site visit. All right, we're going to go ahead and move on to general questions. I had a question about medical records, data reporting period for PRQ deadline. Charts are not all complete. Do we just submit what we have and update upon site visit? So the response is the data should reflect the reporting period that will be used to complete the PRQ. Ideally, and I say ideally, the medical charts should follow suit and should be available on site for the reviewers. However, I do realize that there are some cases that may have not undergone peer review or PI review or have been reviewed yet. If that is the case, you do not want those pulled or available at the time of the site visit, because what's going to happen is the reviewers are going to pick that up. What are the odds out of 120 charts that that is the one chart that the reviewers will pick up, and that will cause them a lot of red flags. So please, if your chart is not yet closed, do not pull it, or don't include it in your case reviews. PRQ-Lifetime board certification. I had to do a little bit of research on this, and I'm grateful that the person who submitted this did. I was not aware of this lifetime boards. So the question is, one of our orthopedic surgeons was grandfathered in the board certification, documented as lifetime duration. This means he does not have an expiration date. How should that be documented on the PRQ and to reviewers? Correct. After my research, I discovered that there is a lifetime board certification for orthopedic surgeons, and this is going way, way, way back. And if you do have a lifetime boarded orthopedic surgeon, what you want to do in the PRQ, in the appendix, you want to list them as lifetime in the column that's asking for the year. And then on site, so that this doesn't come as a red flag, because anything that's out of the norm will generate a flag for the reviewers. And as many of you know, they review that PRQ leading up to the site visit or on their way to your site visit. So then for the site reviewers, what you want to do is have a copy of that certificate, and it's gonna look a little odd because it's not going to have a as you said, it's not going to have an expiration date, but you do want to have that certificate available on site, so that way they're not asking a lot of questions about that. PRQ for pediatric trauma centers. Can you please tell us why ACS cannot have a separate PRQ for pediatrics? It is so confusing to fill out the same PRQ for both. Excuse me. It's not that we don't want to have a separate PRQ for pediatrics. We developed the PRQ, or I should say, let me go back. So the Orange Book, as many of you know, PRQ was developed on the old platform that we previously had for the Green Book, and we are working with our IT and along with their chapter revision process to develop a new separate independent PRQ from anything that you're accustomed to seeing. So for the time being, the current PRQ is programmed, and I don't know if many of you know this, the current PRQ is programmed to only display questions that will pertain to your specific level and patient type. So if you're a pediatric trauma center, say a level 1 or a level 2 pediatric center, then you're going to see questions that are specific for your trauma center and for the level and for the patient type. So for For those centers that are seeking pediatric verification, as I mentioned, although you will not see the word pediatric inserted in many of the questions, because I think that's where the confusion comes in, that you're seeing these questions that same as for an adult trauma center, and we don't have the word pediatric, in that question. They are to be, the question should be answered as if using your pediatric data. So if we're saying, what is your trauma medical director, and we don't say pediatric trauma medical director, please know that we are asking for your pediatric trauma medical director information. So the information that is in your PRQ for the peds, again, talking about the peds, it is all pediatric data that we're asking you to complete. Verification recommendations. Is there a maximum number of not met recommendations that will cause you to fail or result in a clinical deficiency? And I always think of clinical deficiency as a type 1. And I may be wrong. So whether it's a type 1 deficiency or type 2, it's all the same for me. So in response, there is not a maximum number or even a minimum number of recommendations that will result in a deficiency. A center will have various or numerous recommendations which are based on opportunities for improvement cited during a site visit. Centers should make an effort to address these opportunities and recommendations at the time of the site visit. For an on-site focused review, an action plan is required, and within the action plan, the opportunities for improvement recommendations should be addressed. We are not asking to have them implemented. However, the center should demonstrate an effort to address them. So what this really means is that if you have a report that has recommendations or weaknesses / recommendations in them, we're asking you to review those and to, at the time of your next site visit, whether that's a verification visit or re-verification visit or a focus review, we want the trauma center to provide the reviewers sort of kind of like a summary of how you're addressing those weaknesses and recommendations. We're not asking you to implement them because, of course, there are some recommendations that are just not something you can implement within a 3-year period, such as, the ER and the OR are just, too far from each other. There's no way you're going to move an OR room next to the ER. So we know that. So as long as you make an attempt at addressing those recommendations and weaknesses, that's all we're asking you to do. Verification status change. I thought this was a great question, and I hope I don't confuse folks when I talk about this. Sometimes it takes a conversation. So the question is, if a verified center wants to change status to a lower level, what is the process at that time of re-verification? So based on this question, which came from a level 1 trauma center, the response is, if a center is currently verified as a level 1 and has determined that it will not meet the level 1 standards at the time of the renewal, the facility may apply to be verified as a level 2 or 3 at the time of application. So what that means is that if you're currently a level 1 and you're finding that there's things that you just can't meet as a level 1, whether that is your volume, your patient volume requirement, or an OTL, or not having an ICU director who's board certified in surgical critical care, having a residency program or research, there's just like about 5 things that are different between a 1 and a 2. If you know that going into it and you know you're not going to be able to address that within the reporting year, you can definitely request to be verified at a lower level. I don't like to use the word lower level, but as a level 2 or level 3 at the time of the application. And that is, and the same would be true if you're a level 2 or a level 3 and you're seeking to be verified at a higher level, that being a 1 or a 2. You can submit that request during the application process. And, what some trauma centers are concerned about, what if they don't meet the requirement? Well, if you request to be verified at a higher level and it turns out that you just can't meet the level 2 or the level 1 requirement, then you can certainly submit a request following the site visit to be verified at the lower level, if you will, or the current level that you're at. But in both scenarios, it is expected that the center meets all requirements for the level at which it will be verified. So there are some exceptions to that process. So as I mentioned earlier, the OTL form, I know I skimmed through the first part of it, but I do want to state that, and I thought this is a good question as well, does the same orthopedic liaison fellowship prior to 2013 have to be vetted for each survey period, or is it once enough? And I just want to clarify, and I think there's been some confusion on this as well, to clarify, the OTL and orthopedic liaison may be different people. They don't have to be the one and the same. They can be different people. And also to clarify in this, I know this says fellowship prior to 2013, but this also applies to fellowship after 2013. So if the OTL has already been approved and has not changed at your facility, so if you still have the same OTL liaison, or OTL fellowship trained person, and there's not been a change, they do not have to be vetted again. Basically, all we want to know is whether or not there's been a change, and if there has been a change, you have to fill out the form again. If there's not been a change, we do want you to tell us his or her name and tell us that they've been previously approved. We will make an update to the OTL form to include a couple of new categories, such as new, is it a new OTL or previously approved OTL? So we're going to go ahead and update that on the form. Questions about transfers in. We had a question regarding patient received from urgent care clinics. Are these patients considered as trauma transfers? Yes, they are considered trauma transfers into your facility. And I do want to say the same would be true for those trauma centers that have a satellite or freestanding emergency department. I call them satellite, but I think they're referred to as freestanding emergency departments that are part of the hospital system. Those would definitely be transfers into your facility. Performance improvement documentation. The trauma medical director sometimes conducts education and counseling for minor care issues undergoing secondary level review by sending an email to the involved provider. The fact an email was sent by the TND is noted in the PI for that particular patient and issue. Is this sufficient documentation? Absolutely. That is really acceptable documentation. I would also recommend to include a copy of the email in the PI chart, and any verbal discussion should also be noted. So yeah, that's a great practice. If a pediatric patient presents, and please note that I inserted some things in this question only because this person also emailed me directly, and there were some things missing that may confuse some folks. If a pediatric patient presents through triage with a head injury, is stable and does not meet activation criteria, but is found later to have an epidural bleed, is it recommended to activate at that time, or can neurosurgeons solely be notified and then be held to the 30-minute response time? Again, this question came directly to me in a separate email, and I thought it was a good question. If the assessment is done by the advanced provider, and the injury meets activation criteria, the activation should be called. It may be best to call the activation since the trauma attending is required to respond within 15 minutes, and there may be additional injuries that the neurosurgeon may not identify at the point of assessment. However, if the assessment is done by the trauma attending, so there's two scenarios, if the assessment is done by the trauma attending, then they may notify the neurosurgeon since the patient has been assessed. Now, the one thing, if there's not an activation called and the patient meets activation criteria, your over and under triage rates may be impacted by that. So you want to look at this closely and review this through your PIPS process. So there's two scenarios, and again, just review those through your PIPS process. Documentation of GCS. Do physicians and nurses both need to document a GCS scale on the patient record? Is a reading from one specialty acceptable? I talked to Tammy Morgan about this, and the recommendation is that yes, both the nurse and physician would need to document the GCS on the patient records, and she made a great recommendation or reference to go to the NTDS, the National Trauma Database Standards Manual, and look under the data source hierarchy guide, and there's some references there as to how that GCS should be documented. And the reason is that, the GCS can change from one service to another service, so you do want to capture that information. Death cases, clarification of review agenda, adult center treating peds to need to pull 30 deaths with a mixture of both or 20 extra peds. So what I did is, I didn't want to just answer this and confuse folks, so what I did is I added pretty much the death chart pulling list for all trauma centers. So in response to this particular question, that's an adult trauma center that treats peds, the response is number 1, or the first bullet rather. Adult trauma centers treating adult and pediatric, you want to pull a minimum of 30 medical records with a combination of adult and pediatric cases. And that's if it's available. So you may not have a lot of pediatric cases, you may have more adult, and that's okay. So you may just have a handful of pediatric, and that's perfectly acceptable. One thing I do want to mention, and this is true for any of the cases, not just death cases, we're asking for a minimum. Many trauma centers may not have that many deaths, may not have the quantity that we're asking for at the time of the site visit. So pull what you have available at the time of site visit. That's why I have if available on here. Ground level falls. What does the committee want to see for data collection on falls? And hopefully what I'm stating here answers this person's question. There wasn't a lot to this question, so if there's more to it, please feel free to follow up with me at the cotvrc@facs.org. Same ground level fall, same or ground level falls, isolated hip fractures. I know I've talked about this a couple of times, and this differs. This patient population differs for a lot of trauma centers, and this patient population is dependent on your admitting policy. And again, if these are not part of your admitting policy, then you don't have to capture those. However, you may have to capture these for the NTDB. So if these patients meet the NTDS inclusion criteria, they should be captured in your trauma registry. And if the center includes them in the volume admission numbers on the PRQ, this means for any of the data tables in the PRQ, then you must follow all the rules of any other trauma admissions, such as the non-surgical admissions, which is on page 121, which refers to CD 5-18. So again, you may have to capture 2 sets of data points because you have your state requirement that's asking you not to include them, and then you have your NTDS that does ask you to include them. So you may have to capture 2 different states, you may have to capture 2 sets of data, which is creating a little bit more work for the trauma center. But again, if they're part of your admitting policy, then you do want to capture those in your registry. Bypass and diversion, we use the words interchangeable. Some centers do not, but we do at the ACS. Are transfer denials considered bypass, and if so, should we be logging time, etc.? This is a level 1 trauma center. So based on this question, transfer denials from another facility would not be considered bypass. However, and I have great concerns over this, I would be more concerned as to why a level 1 would not be accepting a transfer and recommend that these instances are documented and reviewed through the PIPS process. There are not many level 1s that are denying transfers in, so I definitely would urge you to look at why those are occurring, and yes, I would be logging and PIing why those instances are occurring. Geriatric patients, does ACS expect a level 1 to have a geriatric program, or can they speak to the pathway that is used to manage this population? To answer the question, no, we don't expect a level 1 to have a specific geriatric program. However, if the trauma center sees a high volume of these types of patients, it would be ideal that the trauma center develop some criteria or some activation criteria around geriatric patients, or process guidelines for these types of patients. And if you do have some guidelines and some activation criteria around this, you want to have that readily available at the time of the site visit to demonstrate to reviewers. So we're going to go ahead and move on to CD-related questions. Neurosurgery response. If our neurocritical care intensivist responds to the ED within 30 minutes of notification. Is this an acceptable alternative to the neurosurgeon response time as long as they are documenting that they are communicating with the neurosurgeon regarding the surgical options and plan of care for the trauma patients? And this is being used as an alternate for the neurosurgeon resident or APP mentioned in previous clarification. Absolutely, this is an acceptable practice. As you mentioned, typically we refer to the resident or APPs, but you know, neurocritical care intensivist or an intensivist is acceptable. And if the neurointensivist has been approved to respond to those critical patients' management of care, then that is acceptable as long as that's being documented. Neurosurgeon credentialing. Please expand upon the required credentialing for trauma surgeons to provide initial evaluation and stabilization of the neurotrauma patient. How is this different than the credentials privileges already granted to a trauma surgeon? Are there specific elements that must be included? So I know I've heard Dr. Maxson talk about privileges, and we've talked about privileges. Privileges is it's a little more on the legal aspect than it is on the verification aspect. So we're not going to talk about privileges, but I'll talk about credentialing. So the credentialing process, that is going to be determined or established by your trauma center, and I think many trauma centers have a credentialing office, and typically this is a level 3 trauma center, so when we talk about initial evaluation and stabilization of the neurotrauma patient, we're talking about a neurosurgeon kind of being a mentor, if you will, for your trauma surgeon, or training your trauma surgeon to provide that type of initial evaluation and can perform some type of intervention, whether that's medical or surgical. And in some aspects, that is either doing a burr hole and shipping the patient to another trauma center, you know, stabilizing the patient and shipping them to a higher level of care. So that would be acceptable. And one of the things that I brought back from one of my recent conferences is clarification on pediatric trauma manager. This is high traffic area of discussion at this conference. So I just wanted to bring this back around and have it here for everyone to see. And I do want to stress that this also pertains to adult trauma program managers as well. So, but I did want to just speak to the pediatric trauma manager. So, as the requirement states, a level 1 and 2 pediatric trauma center must have a dedicated pediatric trauma program manager, and that is a requirement. Now, it goes on to further say that in a level 1 pediatric trauma center, the pediatric trauma program manager must be a full-time position dedicated to the pediatric trauma service, and this is the same with an adult trauma program manager, except it says just trauma center, that they must be full-time and dedicated to the trauma program, to the trauma service. Dedicated in both aspects is defined as overseeing and working for the trauma program. And in this scenario, this does not include serving as the program manager for the Children's Surgery Verification Program. Please note that in a level 2 pediatric trauma center, and this would be true as an adult trauma center, the pediatric trauma program manager should be dedicated to the pediatric trauma service, but need not be full-time, and may also serve as the prevention coordinator or registrar, or even the PI coordinator role. So again, the word dedicated came up, and what we're looking for is that they're solely working for the pediatric or the adult trauma program. We don't want the level 1 trauma center program manager doing more than they need to do. It's already a heavy volume role. So I just wanted to clarify that this does not mean that they can also run the ED or serve as the program manager for the Children's Surgery Verification Program. Although it is a verification program, it is not linked with the trauma verification, so we're 2 independent programs. Question about radiology response. Radiologist response for intervention, is this from Time of call to start a procedure or patient in room ready. We've gotten several of these calls in the last month. So the response is tracked from the time of the call, so when the call was made for the service, and to the time to the service responding to his bedside. It is not to the time of incision or procedure time, as some may think. ICU coverage: would a critical care trained nurse practitioner qualify as a credential provider for coverage of the ICU in a level 3 center? So based on Chapter 11 on page 81, Table 1, coverage must be provided by a physician, and that physician could be either the ED physician or an intensivist. I am going to seek even further clarification on this with the chairs, and if there's an update to be reported, I will bring that back in the next webinar. Specialty services for ophthalmology. In a level 2 center, do we need to be able to provide 24/7 ophthalmology surgery as well as plastic surgery? For level 1 and 2 trauma centers, OMFS and plastic surgery services are required. It is a requirement for both these levels. The Orange Book is silent on the call schedule piece. It doesn't say that there has to be a call schedule. However, the expectation is that if the trauma surgeon requests a consult from OMFS or plastic surgery, there must be a process whereby who is on call for OMFS or plastic is documented. So basically, the reviewers don't want to see anyone, trying to find a name. We want to see that there is a schedule or there's a name that you can go to if there is coverage for OMFS and plastic. In addition, these specialists are not required to be in-house 24/7. However, based on institutional guidelines, the specialist must be available in person at bedside at a predetermined time when the consult is requested. Again, many of the reviewers have stated that, during a site visit, they'll ask who's on call for MFS or plastic or any of the other specialties, and people are not aware of who's on call, but please be sure that if you are asked, don't be surprised. Number one, don't be surprised if you are asked who's on call for these specialties during a site visit when they're walking through your trauma center, and you want to be prepared to present some type of documentation of, yes, I know who's on call for that service. So again, just be prepared to have someone's name. For blood bank compliance, does FFP, fresh frozen plasma, need to be thawed within 15 minutes or available to be thawed within 15 minutes? It's the latter. So it is not expected to have the FFP thawed within 15 minutes. We realize it takes much longer for that to happen. It takes a lot longer for it to be thawed within 15 minutes. So therefore, the expectation is for the FFP to be available, and then you can begin thawing that within that 15 minutes. ATLS, interns work under the supervision of the attending. Do they need ATLS if they are present at the initial resuscitation? So I'm going to interpret this that if the interns are members of the trauma team activation, whether that's the high or limited activation, and will participate in the evaluation and resuscitation of the trauma patient, they are required to be current in ATLS. With that said, if the interns or PAs see trauma patients during the consult phase, they are not required to be current in ATLS. So I'm going to go back to the first statement when we're talking about the interns. So if the intern is under the supervision of the attending and they will have no hands-on with that trauma patient, meaning they're not going to participate in the evaluation and resuscitation efforts, then they will not need to be current in ATLS. Again, we only want those that are going to be hands-on the patient and have some role in the patient's evaluation and resuscitation to be current in ATLS. And then there was a question about whether or not interns and PAs who are involved in the consult phase, whether they need to be current in ATLS, and they do not, even though they may ultimately end up as a trauma patient or as an activation. But if they come in as a non-activation, we're not asking them to be ATLS current. TQIP enrollment for the consultation visit will we be required to have 1 year's worth of data for reviewers available in the TQIP. No, you're not required to have data in the TQIP. What we're asking for consultation visits, let me go back. For new trauma centers seeking a consultation visit, if the center is fully enrolled, that means assigned contract and payment in the program but has not yet submitted data or received a benchmark report, the center will not be cited a deficiency. For new trauma centers seeking a consultation visit and it has not applied for TQIP, the deficiency will be cited. However, at the time of the verification visit, the center will be expected to be fully enrolled in TQIP. So we're not asking for you to be enrolled in TQIP at the time of consultation visit, but if you are, that's great. And if you have submitted data, that's great. But if you have not, that's also acceptable. But the expectation is that for a verification visit that you are enrolled in TQIP. Again, for verification, if you're enrolled but not yet submitted data, that's also acceptable. Registry cases. What is the latest 80% criteria for the registry? Cases entered or cases closed? I'm not sure if there's been some discussion on this, but the requirement has not changed. The percentage of completed registry records entered within 2 months of discharge, and the threshold is 80%, and that is for cases closed. So centers are encouraged to stay concurrent. I know this may be challenging for some trauma centers. I've heard that there are some centers that set the bar pretty high, such as, if there's cases that they've come over the weekend, they want them entered within a week's time. Again, that is a pretty high bar set by the trauma center, and that's independent of anything, that is set by the trauma center, is dependent on the number of FTEs available to provide that type of support. So that's a pretty high bar, but again, that is not a requirement for us. We're asking that they are completed, entered within 2 months of discharge, and 80% of the time. Registrar, can you please provide a staffing ratio breakdown? The Orange Book is very basic staffing, stating 1 FTE per 500, 750 cases. Is there any plan to change the requirements for trauma registry staff from the 500, 750 patients? So as many of you have heard me early on and over the course of several webinars and several conferences, we've talked about this many, many, many times. We are going to make a change to this. It's not, we're not going to keep it as is, but we are going to be changing this number and the requirement. I don't know what that number may be. It may be 500 and under. It may be 750 and under. I don't know. That's why we need your help to go onto that stakeholder website and tell us what you think is an ideal number, but you also have to provide us some recommendations or some data to support your findings. I can't really provide a ratio breakdown without knowing a lot of specifics of your trauma center. All I can really speak to is the recommendation or the requirement that is in the book, and that is, you need 1 FTE for every 500, 750 admitted. As I mentioned before, that word admitted is what's really causing a lot of concern for trauma centers, because administration is looking at that number or not looking at the overall role that the trauma registrar has to do. And that being, you're capturing data points for not only the NTDB, but you're also capturing them for TQIP. And if you're a state that requires you to capture additional data points, that's a third element to your job. In addition, registrars also have to, generate reports, you perform data analysis and such. So, I mean, it goes on, and I know administration is not looking at those other duties, and I hope that by having it on the slide that you can show this to your administrators and hopefully get more support for your registry. But I do want to mention that we are looking at this. This is definitely on my list of things that we are going to be looking at. And again, I don't know what that number is going to be, but I do know that from many discussions that the word admitted will be omitted from that requirement. Universal alcohol screening, standard for ETOH screening states all. Is there an acceptable percentage other than all? Some injuries such as TBI prevent screening. You know, this is another one that's come up, and I am going to be working with my chairs to even drill down on this a little bit further. But for the time being, we did change this from all patients to the following. All patients that meet the NTDS trauma inclusion criteria with a hospital stay of greater than 24 hours, for at least 80% of the patients should be screened. This does include all injuries. That includes ortho and neuro. Again, there's some follow-up that I am going to be doing with our chairs to even drill down on this further, and if there's an update to this, I will bring that back to the webinar, next month's webinar, that is. Research, clarification, I just want to just touch on this really quickly because there's been some discussions around this. Articles that have been approved and accepted, approved or and accepted for publication are acceptable to use to meet the research requirements. I did not realize that this was not on the clarification document, but I will add this to the clarification document. But you do have the slide to show administration that it is acceptable. I do want to stress the importance of all research work must result from work done at your trauma center. Work done in collaboration with other trauma centers and participation in a multi-center investigations may be included as well. So we're talking about work done at your facility, or if your trauma center is involved in a multi-center project, that is also acceptable. And the other one I want to stress is if the center has a new provider, surgeon, physician, or whomever, in which she did research at another facility that is not part of a multi-center project, but they did research at their facility and it was published or accepted, that research, and they are now on your service, that research cannot be counted to meet the requirement at your facility because that data was not from your trauma center. So I just want to make sure that was clarified. CME, specialty specific. Does trauma-related CME need to be specialty specific? The CME should be applicable to the surgeon or physician's area of expertise or their specialty. However, not all 48 hours are required to be specialty specific. What we ask for is that there are some that are specialty specific, but that the CME be relevant to the management and care of the injured patient. So it could be a mixture of both. CME prorated, I've covered this many, many times in the webinars, and I did not break this down for this person. So I'm just gonna go touch on this really quickly. CMEs will be prorated for new centers seeking verification of 16 hours annually for all specialties. For those centers that have new hires or residents that come in July or June, July, during the 3-year verification cycle, so if you have new hires during the 3-year verification cycle, CMEs will be prorated based on when they started on your trauma service or from their date of hire. When completing the PRQ, questions asking if all are in compliance for CME, make sure that you answer that yes. Otherwise, if your answer is a no, what it's going to do is going to trigger a deficiency. So if you have some new hires on your service or some new residents, make sure that you're answering that yes. And in the appendices, type a symbol or an asterisk next to the new hire's name or the new residence and add a note in the blank field at the bottom of the page. So there's a bunch of lines and blank lines. You can enter something down at the bottom so reviewers know that, yeah, they're not short, or they are short, but that it's not a deficiency, that they are prorated based on that they're a new hire. And for the person who submitted this, again, to calculate the hours, you would just base it on the time they started on your service. So I'd like to take this opportunity to thank everyone for participating in our webinars, and thank you for joining today's webinar.
Thank you, Molly, and thank you everyone for attending the webinar today, Trauma Verification's November Q&A web conference. If you have any other questions, please contact cotvrc@facs.org. On behalf of Trauma Verification and our presenter today, thank you so much for joining us and have a great rest of your day.